Question remains is why we should consider this newer implant like dual mobility when we already have good survivorship with conventional hips. And when in the past we had bad experience with use of large head metal on metal. It's because even after so many years of conventional hip, instability still remains one of the main concerns, with dislocation rates of up to 7% in primary scenario and 25% in revision scenario. And in fractured neck of femur, the dislocation rates can be seen as high as 22%. Dual mobility hip has inner metal or ceramic head which articulates with outer poly head, giving larger range of movement prior to impingement. Jump gap is increased with this design, offering greater stability. And this was the reason for the larger interest and increased number of publications over the use of dual mobility in the past decade. In our institute, we have operated 125 patients between January 2015 to 2020. All these data were retrospectively analyzed. Patients with less than 12 months follow-up were excluded from the study. Majority of our cases were fractured neck of femur, followed by osteoarthritis and AVN, and we had 14 cases of revision hip. Aim of our study was to evaluate clinico-radiological outcome of dual mobility total hip in both primary and revision scenario. Patients were assessed clinically and radiologically at 6 weeks, 3 months, and last follow-up. These are some of our cases in neck femur fracture and degenerative arthritis, a patient with prior hip surgery. In revision scenario, where in case 1, Charnley stem was revised, and case 2, where patient had periprosthetic fracture, which was revised with a revision THR. 5 patients were lost to follow-up, thus 120 patients were analyzed with a mean follow-up of 2 years. 54% of the patients had good clinical score, and only 3% of the patients had poor outcome. There was no dislocation rate seen in our study. All patients were able to assume activities of daily living. We had 3 complications in our case series: loosening and failure of acetabular component, which was revised with a cage and cemented cup; superficial surgical site infection, which was dealt with wound debridement; and intraoperative femur fracture, which was fixed intraoperatively with a plate. These are the limitations of our study. On literature review, dislocation rates with dual mobility THR is as low as 1% in primary hip scenarios. In fractured neck of femur, it is 0.5%, and in a revision scenario, it is less than 4%. When comparing the survivorship with primary designer series, there was 70% survivorship seen at 25 years with a 4% dislocation rate. Now, when assessing the same results in other hands, this is a meta-analysis of 10,000 primary hips with a survivorship of 98% at 8.5 years with a dislocation rate of less than 1%. And in revision scenario, survivorship of 96% with a dislocation rate of less than 3%. One specific complication of this particular component is intraprostatic dislocation, seen as characteristic bubble sign on X-rays. However, this was seen with 22 mm head and older generation of polyethylene. Nowadays, with 28 mm head and newer designs of dual mobility, there are no reported incidents of these complications. So to conclude, dual mobility hips is a good solution for instability in both primary and revision scenario. We have seen good early results which are comparable to conventional hips, and survivorship of this implant when literature review is done is equivalent to other conventional hips. Thank you.